Thank you, Peter. I appreciate this opportunity. And as Peter mentioned, we work in collaboration with WHO AFRO as well as AFINET team members and our CDC colleagues in the Center for Global Health. And our work has been supported by the Defense Threat Reduction Agency. So I'd like to acknowledge all those contributors to our work. And as Peter said, Dennis unfortunately was not able to come to the meeting. And so we sort of scrambled last night to combine his presentation with the presentation that we have to present this work to you, and I'm very honored to do that. So I'd like to talk with you about a really, what we think is a very important and innovative initiative in Africa. Some of my team members here are in the audience as well, and we're happy to answer any questions that you might have. And so the goal here, I think, is you might understand, is to try to develop a pattern of thinking about developing e-surveillance, and I'm using that as a term to encompass the workflow around public health surveillance in Africa. So the issues that we face there are common issues around the world, multiple independent electronic disease surveillance systems that exist that don't interoperate, as this bullet indicates, limited interoperability, varying effectiveness of these types of systems. And there's a lack of agreed upon informatics standards and guidelines as well, and the lack of a system-wide planning or exchange of ideas. So in the face of these problems, CDC and AFINET have combined forces with support from DITRA to think about how do we work from the policy level through the offices in Brazzaville with WHO AFRO, and also at the grassroots level to think about how to do an assessment of e-surveillance capacity that would inform not only what I'm going to be calling an African Informatics Surveillance Advisory Board, but also provide support to the various countries in developing strategic plans. So there have been several meetings. One of the last ones occurred in Pretoria in May, which was convened by AFRO and supported from DITRA, where 7 African countries were represented, and they're listed here. And the ministries of health of those countries representing the One Health concept, which is certainly the future of public health surveillance, which combines veterinary public health, veterinary laboratory medicine with human health and human laboratory. And there were 5 partner organizations represented, Gates Foundation folks, DHS folks, the Global Fund, as well as USAID and the World Bank. So we were collaboratively developing a strategy so that we would be able to engage stakeholders in this process. The results of the preliminary environmental scan from this work yielded 4 major themes, and I think these probably will be very common to you. They were discussed at length in the workshop yesterday. The first is policy and legislation, infrastructure, workforce, and external and internal resources. So there are themes that emerge that are areas of intense interest. So e-surveillance in Africa, the proposal was put forward to strengthen the national capacities for e-surveillance and reporting as defined by IDSR, the Integrated Disease Surveillance and Response Project, which is an integrated surveillance effort that's been ongoing in AFRO for about 16 years. Looks at functions for public health surveillance, detection, reporting, analysis, etc., as opposed to siloed surveillance systems. And also the IHR framework, which now is, we'll talk in a moment, are 2 key public health policies that are promoted by WHO. So the first proposal was to establish an African Surveillance Informatics Governance Board, which would have very important policy responsibilities, chaired by AFRO with members from Ministries of Health and Ministries of Agriculture in AFRO, and to establish what would be a technical advisory group called the Surveillance Informatics Technical Advisory Group of worker bees, if you will, that would actually have the technical and subject matter expertise knowledge to be able to, in an informed way, review various surveillance tools and also to embrace or to adopt public health informatics standards, HL7 messaging, ICD-10 codes, etc., to establish this interoperability, which was one of the driving forces. So the CITAG then, in this policy idea, would report to the advisory board and also to other members and provide this technical SME subject matter expertise. So the secretariat then would be assigned to both these groups and provide the sort of logistics support so the two groups could work and function appropriately. And then implementing partners would guide the work, and that means that our support for AFINET being the African Field Epi Training Network, which helps and supports and serves the 20 FELTPs or FETPs in Africa, would provide the cross-cutting support. And their mission was to broaden the training of epidemiologists to include public health informatics, something that Peter and I were discussing before the meeting today. So the outcomes of this meeting led to the consensus on the need for a governance board and a technical advisory group and recommendations for the board's operation. And there were additional recommendations that came from this meeting, developing an implementation plan. And we're actually living out this in a weekly meeting that we have with CDC and colleagues in Washington, as well as WHO AFRO. So the intention here is to promote and strengthen the public health work practice. I mean, Peter and I were discussing, I'm an epidemiologist who I've been forced, if you will, to learn public health informatics. So I'm like an amphibian. I can walk on the water or swim in the water. But the workflow process should be supported by the information technology, not vice versa. In other words, the user requirements of the workflow should dictate how the information technology support should be structured so that it helps the epidemiologists do their work better, faster, and cheaper. So also the policy in Africa is IDSR, which is integrated surveillance, looking at functions of surveillance as opposed to specific siloed programs. And also, of course, IHR, the International Health Regulations. We talked about this in our workshop yesterday. So we also obviously have AFRO has the intention of developing a very thoughtful, well-informed policy that then would be presented to the African Union meeting next summer to get the endorsement throughout WHO AFRO. So there obviously has to be a clear communication plan and a proof of concept model. So the e-surveillance governance board, in this case it's a temporary board until the full board is formed, would have the responsibility of endorsing, adopting, embracing standards and interoperability, guidelines, policies, and strategies for Africa, and provide a forum for discussion and planning and advocacy, obviously. And it would also account for certain donor and stakeholder interests. For those of you who've worked in Africa, you know that, for example, in Uganda, there have been over 20 mobile phone projects that have come and gone. We call it pilotitis. The project comes, and in a 4-year period, it's gone. There's not an attempt to look at sustainability for the project or leveraging it for other opportunities. So this is a problem. In fact, the Ugandan Ministry of Health halted projects related to mobile phones because of this lack of governance and policy. So this effort, with leadership support by CDC as well as DITRA, provides for the support for the WHO AFRO team to provide the guidance in this way. And obviously stakeholders are interested in funding and doing projects in Africa, and we want to provide an environment where the stakeholders can be assured that their investment is appropriately used and also can be leveraged, that pilot projects in one country, if they work, could be leveraged and expanded to other countries. And so this policy and the technical advisory group would provide the sort of standards base to establish what would be best practices for e-surveillance. Remember, we're talking about e-surveillance, not e-health. E-surveillance is a domain of work that intersects with the health community, but it's not hospital emergency records, emergency medical records, but it does intersect with that. We're talking about the sort of standard concepts of public health surveillance. So the concept of the board has been pretty fully vetted, I would say, and the next steps, we have planning teams working on developing an assessment guideline. I'll share that with you in a moment. And there is an initial plan of action for the board to consider. And obviously there'll be a marketing and communication message that comes from this group, which is supported by USAID, DOD, as well as CDC and AFRO, and AFINET are the key players. and the Gates Foundation. And so there will be a marketing sort of opportunity to vet the policies, to vet these ideas, etc. And we want to obviously work in collaboration and coordination with all of the e-health initiatives, the open source, Open MRS, which is very, very strong project. So I'd like to quickly talk about some of the objectives for our specific work in supporting AFINET, to develop, if you will, establish country-level work groups. We're all about sustainability. We're also about building from the grassroots up. So from our point of view, it's important that Africans do the assessment, that Africans develop their own governance model, and that we promote and support the open source development among African developers, which is a business development concept. And so, but we're also committed to One Health, meaning the alignment of veterinary and human health, and to provide evidence-based information so this governance board can effectively manage their approaches. So our aims in our project are, as I mentioned, to establish these five country-level work groups, which are a mix of veterinarians and epidemiologists, in and through the leadership of the directors of the field epi training programs in the countries that have been chosen, along with the WR representative in each of the countries. So the WR and the director of the FETP or FELTP would choose the 5-member working groups, which would be coming from the Ministries of Health and Ministries of Agriculture, and they would be provided, these working group members would be provided training, computer assistance, and to do the assessment. These are the countries that have been chosen for the pilot. We're fortunate, actually, that some of the representatives are here at this meeting. Representatives from the FETP, for example, from Nigeria is here. I don't think she's actually in this meeting right now, but we met and talked with her last night about the project. So right now we're developing with CDC an assessment of e-surveillance, and the intention also is to do an inventory and an evaluation of e-surveillance tools. And then this information that's yielded from an assessment would guide the development of strategic plans that are country-focused, transnationally aligned, for the development of a plan for the rollout, so to speak, of e-surveillance. This would enable and build workforce capacity also, and provide this sort of sustainability, which is a driving force in our work. So our phase 1 is outlined here to work with the governance board, which we've been doing to do the literature reviews, providing all of the background information for the board, and to develop with CDC this assessment tool, which would be used by these in-country work groups, which would inform the governance board, but also inform the strategic planning that happens at the country level. The project timeline is this project really began last summer. The first phase is to establish this assessment tool to build, stand up, if you will, the country-level work groups, provide training for them to do the assessment, to provide that information for next August AU meeting for AFRO to present this as a strategy. And then phase 2 is to take this information that would lead to strategic planning in each of these countries. Presumably the tools then would roll out for the other countries in AFRO. So the country-level work groups are being formed right now, and they are appointed, as I mentioned, in collaboration with the WR as well as the director of the FELTPs. And they are a mixed group, which is a challenge of its own, but necessary. We firmly believe that the One Health concept is an absolute future vision for public health surveillance. And so this is the work that's being done right now, which, again, we hold as sustainable. We have and we're going to hold ourselves to that account as well, having a monitoring and evaluation plan for sustainability. The second phase, as I mentioned, is developing the strategic plan. So we're in the process of the first phase, which is the conduction of the assessment, doing the technical work of developing the assessment tool, etc., and that will be vetted appropriately so that everybody has a chance to have their say, and presumably adopted by AFRO as their standard e-surveillance tool. There is no such global tool right now. There are tools looking at e-health and tools that look at other elements of ICT, but not for public health surveillance. So the benefits to the pilot countries, we believe, obviously, are beginning this momentum toward developing One Health capacity, also the knowledge of the importance of public health informatics and incorporating that into the thinking of public health surveillance aligned around IDSR and IHR is the sort of mission. We also will provide training materials to the workforce, the groups that are formed. And of course, AFRO then will see the outcome of this, a blueprint for operation that they can not only have been a part of from the very outset, but can roll out to other African countries. We all know the level of intensity of business development in Africa, which is really profound. But we also know the confusion that exists now among all of the electronic systems that are being promoted. So the toolkit that we hope will be developed and planned will be this country assessment, which we're developing right now with our colleagues with CDC, plus a tool, an inventory of these surveillance tools, which we're doing now through the literature review, and then the strategic planning framework, which would not only help the 5 pilot countries with it, but then could be rolled out. So we intend for this strategic plan to not be prescriptive, to not be exclusive, and to not be redundant. Those are the principles under which we're operating. And I think that we also have sort of a real good commitment from our stakeholders. They've been involved in the meeting planning for quite a while. And also there are several projects that are supported in Africa. There is a One Health initiative supported by USAID. It's not an ICT initiative, but it is an initiative to bring veterinarians and epidemiologists together. And these work groups then would help inform the technical advisory group. So you have information collected at the technical level from the grassroots that informs the policymakers, and then the policymakers provide their imprimatur on the technical work. So it's real important to have the policy level discussion as well as the worker bees that work at the technical level, who know public health informatics and can provide the best advice, if you will. So there are certain principles that we have committed ourselves to. One is sustainability. I've mentioned that repeatedly. The other is the respect for national sovereignty and data, which is this element of trust that we've discussed related to the MERS coronavirus outbreak right now, in fact. That has to be established right up front, as well as local ownership of the data, local ownership of the tools, local ownership of the outcomes of the work, plus the development of local business opportunities. We are all about providing an environment for local developers in Africa to build out tools to support public health surveillance through XPRIZE incentives and other incentives, because there's a great demand for this. Plus, we want to promote local communities of practice, and finally, the concept of mindfulness is in our work. So our IT approaches, which many of you will recognize, are that we're committed to open source development, open architecture, having standards-based health information technology, having semantic and syntactic interoperability among tools. These are the principles where the technical advisory group will sort of orient themselves around, as well as federated information exchange. I wish we had these principles in the United States. I think.
You're not alone, Scott.
So I know I'm speaking to the choir here, and these principles obviously are ones that everyone I think would align to in the public health workflow. So Peter, thank you for this time. I want to briefly acknowledge the members of the Joint Partner E-Surveillance Working Group, and we had our last meeting yesterday morning. We'll have another meeting next Wednesday, and it's represented by these stakeholders and visionary leaders, and especially to acknowledge the Defense Threat Reduction Agency, who has had the foresight to think about investing in the development of policy and standards-based guidelines, which is very appropriate, and the CDC, who's provided this great technical support, as well as all of our colleagues in AFRO, and AFINET, with whom we work very closely. Thank you.